Real pleasure to talk about theranostics in nuclear medicine, new neuroendocrine net therapies for the 21st and 22nd centuries. And in this talk, I'll be concentrating on alpha therapies for neuroendocrine tumors. This is a standard neuroendocrine tumor cell, and as you can see, there have been a number of targets that have been used to try to treat them, both either by chemotherapy or radiation therapy. The most recent one is targeted peptide therapy against somatostatin, which is overexpressed in neuroendocrine tumors on the tumor cell. And as probably most of you know, the first target was for imaging using Indian DTPA. It was also used for some therapies, DTPA octreotide. And the cartoon just shows that there's a somatostatin receptor target that delivers a radioactive tracer. In this case, first indium. It was disappointing, but then yttrium-90 was used, and because of renal toxicity, there was a switch in the 2000s to using lutetium-177. And this just shows that patients with neuroendocrine tumors, if they're well differentiated, there's uptake, as you can see here, in the patient's liver, metastatic disease, and with an FDG scan, which looks at undifferentiated tumor, there's no uptake, versus poorly differentiated tumors where they lose their somatostatin receptors and become more aggressive, and in this case, they take up fluorodeoxyglucose. So one of the problems with these therapies is as the tumors become undifferentiated or poorly differentiated, they may not respond as well to the targeted peptide receptor therapy. And as almost everyone knows, this drug was just approved in the last roughly year, somatostatin labeled with radioactive lutetium-177 or Lutathera. And this just shows a dramatic response to the lutetium, a patient with a large tumor in their neck. And after subsequent treatments with the lutetium, the tumor is still there, but it's significantly smaller. So this patient got a significant benefit from the radiotherapy. And there was another one trial that showed in a double-blinded study that patients given PRRT therapy with Lutathera had significantly prolonged progression-free survival compared to those that were just placed on long-acting somatostatin. So this became quite a significant advance in the treatment of neuroendocrine tumors. So is there something better on the horizon than lutetium-177 dotatate for neuroendocrine tumors? And the answer is yes, and these are alpha emitters. Probably one of the most common ones currently being looked at is Actinium-225, but as I'll be showing, there's a company that's just trying to commercialize Lead-212, which is also an alpha emitter in France, and they are actually further along than people using Actinium to treat neuroendocrine tumors. So why is alpha particle therapy in some respects preferred to the Lutathera or the beta emitters? Beta emitter is an electron, and an alpha particle is a helium nucleus. The helium nucleus is much, much larger, and therefore it's much more destructive to DNA than a beta particle. But there is either an advantage or disadvantage to the alpha therapies, which is they are not nearly as penetrating. So a beta particle can kill adjacent cells, whereas the alpha particle tends to just target within a few cells of where it attaches. And this is shown in this cartoon, just where the neuroendocrine tumors are shown here as rounded dots, and the alpha particle is able to destroy these three, whereas the beta particle can go some distance and target other tumor cells. So there is an advantage to the beta particle, but the alpha particle is really destructive, and any cell that's within a few cells of the alpha particle attaching will be killed. And it's not necessarily the case with beta particles. So in most of the treatments with actinium have been done in prostate cancer patients, not neuroendocrine patients. And this is one of the most viewed patients, I think, in the history of nuclear medicine, because this patient was treated with lutetium PSMA, which targets prostate cancer. And three therapies held the cancer in check. It maybe regressed a little, but certainly it did not disappear. But then after 3 cycles of alpha therapies, the patient had a complete remission. So we think that alpha therapies are potentially able to achieve much higher remission rates in patients than beta therapies with lutetium. The other advantage of them is because they don't penetrate. If there's disease involving radiation-sensitive organs like the bone marrow, in this patient's case, there would have been a lot of marrow destruction from the lutetium therapy. The patient was able to achieve a complete remission with just 3 therapies of the actinium-225 or the alpha therapy. So there's tremendous interest in this. This is a patient that received actinium dotatalk, again, having significant number of tumors, had 1 therapy where it got almost a complete remission. And after the 2nd therapy, he still had residual disease, but much, much less than with the initial therapy. So there's significant hope that this will be quite an advance over lutetium in the treatment of neuroendocrine tumors. I'm going to talk about one of the few clinical trials that was shown last year, a year ago, at the Society of Nuclear Medicine meeting. There's Excel Diagnostics and Nuclear Oncology Cancer Center in Texas was where it was hosted. It was a first-in-human dose escalation of alpha medics, which is a targeted alpha emitter therapy of neuroendocrine tumors. The study had 16 adult patients, 7 men and 9 women, with age range from 27 to 75, with biopsy-proven unresectable or metastatic NETs from different primary sites. And in a dose escalation protocol, the lead-212 dotamatate agent was given in 4 cycles at 8 weeks. So they got 4 cycles of the lead dotamatate every 2 months. And the researchers were able to extend treatment in 1 cohort up to 22 millicuries with no significant hematology, renal, or hepatic toxicities. And there were dramatic decreases in tumor burden and a positive impact on quality of life in all patients. In fact, in the last group, they all went on to show remission. And that's what I'm going to just show here. So this is a 71-year-old woman who was diagnosed in 2014 with bronchial carcinoid, and the tumor was encroaching on the aorta and was not resectable. It's treated with chemotherapy, long-acting somatostatin, and everolimus. And once the disease progressed was confirmed, they were referred to the clinical trial and started on the AlphaMedix trial in 2019. And the disease, the patient was on constant oxygen, and her disease was located in the left lung, in the left pleural surface, and on the left of the mediastinum. And this just shows after the first 2 cycles, the patient had almost complete remission of the cancer, and after another 2 cycles, the disease was essentially not visible on the gallium dotatate images. So this patient went from being disease-ridden to disease-free. Another patient had extensive liver metastases, and the same story. After 2 treatments, there was almost nothing to see in the liver, and it looks like if there was anything, it was very minimal disease left in the liver, if any. So again, looks like this patient had a near complete remission from the neuroendocrine tumor. This chart just shows that there was nothing before and after in terms of damage to the kidneys or damage to blood components, white cells, etc. So there was almost no toxicity from this treatment. So unfortunately, this is not a double-blinded trial. It's very early. We don't know if all patients are going to respond this well, especially when they have undifferentiated tumors without the targets. But basically, the safety study showed it was safe and highly effective for treating neuroendocrine tumors, and it was effective regardless of the location of the primary tumor. And the first 3 patients in the cohort 4 monitored 15 months since the initiation of treatment. 3 patients enrolled in the expanding cohort. 4 were dosed with 4 cycles of treatment with very encouraging results, as demonstrated. So the big question is, of course, where can patients get this? And the answer is, unless they're enrolled in a clinical trial, probably nowhere in the advanced world. But there is a carcinoid and neuroendocrine tumor society in India, and they are referring patients to 2 centers for actinium therapies. And I managed to go to their website. I'm not endorsing this at all. This is not an endorsement to go to India necessarily, but this is the only place that I know where you can probably go and have a actinium-225 DOTATOC therapy at a cost of $11,000 per cycle. So about $50,000 for total treatment. The center here is in Delhi. Again, I'm not suggesting that or advocating anybody go there. I have no idea whether this is a good center or whether it's even safe, but this is the only place that I'm aware of outside of a handful of centers in Australia and Germany where the therapy is available. So that's the end of my presentation, and I'd be happy at the conclusion to take questions in the live session.